I'm Dr. Derek Hines. I'm the founder of Acadiana Pain and Hero Health. If you're new to that environment, we integrate the best technology, the best treatment, the best research to try and change the ability to heal and achieve health. So we're trying to put all of those things together in a way that I think is not common in today's healthcare system. When Chloe came to me, when Dr. Hammett came to me and was like, I want to take that model into the pelvic floor world, of like, that's exciting, but let's do some digging. Like, let's do some research on it. And one of the things that blew me away from the very beginning is how prevalent and poorly treated pelvic floor health is. The estimates that you see right now, everybody talks about how underreported they are, and it's like 50% of all women deal with some version of pelvic floor dysfunction, and up to 80% of women who have had pregnancy. And those are underreported. And I'm like, okay, so you're just saying everyone. Let's just say everyone. And when you start looking at what we're doing for it, this is somewhat indicative of the healthcare model. We are doing a lot of symptom management. Let's kind of pacify the symptoms and hope that they go away. And if they don't, well, then that's kind of your fault. So, sorry, good luck. That's my exciting thing about that. And y'all are going to hear a lot of kind of our philosophy around treatment and healing in this. But when you look at what you can do from a healing standpoint, when you tell the body to heal, and you give the right inputs with the right technology to heal the muscles, to break down scar tissue, to improve nerve function, to get all of the structures around there healthier. The opportunity to take an area that is very poorly treated and the outcomes are not good, and flip that over completely to where it's like, this is one of the things that we can see very consistent improvements with massive gains, without leaking, without pain, without all of the things that everybody struggles with, excites me to no end. And you couldn't find somebody who's more passionate about it, who's more passionate about her patients, about giving them the best care than Dr. Chloe Hammett. So please give her a hand.
Go girl.
And you can introduce your co-pilot.
Oh, yeah. All right, hello everyone. I'm Dr. Chloe Hammett. I am a pelvic floor physical therapist here at Acadiana Pain, and I am extremely excited to be bringing pelvic floor therapy to Acadiana Pain and Performance. It is very much a population that is underserved, and we want to be able to educate all of you and empower all of you to take some action when we're talking about some of the pelvic floor dysfunctions that we'll mention today. This is Miss Jordan Delaney. I'll have her introduce herself, but me and her have been training together to get this program going, so we're super excited to be able to offer this to all of y'all, and let's see how it goes.
My name is Jordan Delaney. I'm one of the therapists here at Acadiana Pain, and Chloe is someone who, you know, she's like, oh yeah, I've always been interested in pelvic floor. Yeah, let's do this and everything. And since my beginning of practice, I was like, no, I'm not doing that. That is very intimidating. Not many people talk about it. But as I started digging into this, I found how empowering it is, how much this is really needed. So I'm really excited for this.
Right. Y'all ready?
Yes.
Alrighty. So we're going to start with just some statistics just to show how prevalent pelvic floor dysfunction is and how many people it impacts. So some of the statistics out there, like Derek was talking about, 56% of women have urinary incontinence, 10% have fecal incontinence. We have up to 50% that'll have pelvic organ prolapse over their lifetime, so half of women will experience some of these symptoms. We have 19% of women that experience pelvic pain at some capacity, and then 13% of those women with any of these symptoms end up having surgery for it. And these statistics really just highlight of like how prevalent it is, how many people it affects, but also it just highlights the need for pelvic floor physical therapy, and it is something that we can address and fix. And that's why we're so excited about this, because we can impact all of these women that are having these symptoms. So what is the pelvic floor? So I'm going to come down here because we're going to talk a little anatomy and I want to be able to point out some structures. But the pelvic floor, really, we're going to use this analogy a lot. It sits like a hammock at the bottom of the pelvis. And it's a network of muscles that provide a lot of functions to the trunk, to the pelvis itself, and to the organs that lie within it. So first, let's talk about the bony structures that these muscles attach to and how they function. And Ms. Jordan Delaney is going to show you up on the stage too with a 3D model. And we will pass this around later on so you can kind of see it, feel it, and know exactly what we're talking about. So we're going to start here. These two like elephant ear shaped bones here, those are called your ilium. And at the top, if you put your hands on your hips, those are your iliac crests. So when we think about the pelvis, think of it as a bowl. And at the top of that is those ilium, and they provide the opening of that bowl. Now, if you put your hands underneath your seat, under your butt, and then rock side to side, and you feel those little bony pieces pushing into your hand, that's called your ischial tuberosities. They sit on the bottom and outline the opening at the bottom of the bowl. On the front, we have your pubic bone. This is where a lot of the attachments to our pelvic floor muscles are. They start there and they actually wrap around to the back. If we flip it around, we have the end of our spine, which is the sacrum. So you can see on that model there that we have a few of the lumbar segments, and then at the very end of the spine we have the sacrum. Now at the very tip, you see that little pointy piece, that's called our coccyx or tailbone. That's the other attachment to most of our pelvic floor muscles. So they run front to back from the pubic bone and wrap around to the coccyx. And then they run side to side from ischial tuberosity to ischial tuberosity. So that's all the bony structures. And that just goes to show how it's connected to the spine, how it's connected to the hips. So if you can see on the sides, there's these little concave pieces. That's where the femur attaches onto the pelvis as well. So when we talk about it, and we'll say this many, many times, when we talk about pelvic floor therapy, it's not just addressing these muscles within the pelvis. We have to address the lower back. We have to address the hips, or we're not getting the full picture. All right, let's talk about the muscles themselves. So the pelvic floor is consisted of 3 layers of muscles. You have a superficial, an intermediate, and a deep layer. The superficial layer, we have this right over here, this superficial transverse perineal muscle that runs from side to side from the ischial tuberosity to ischial tuberosity. On either side of the vaginal opening, we have the bulbocavernosus, and then out here on what's called the pelvic rim, we have our ischiocavernosus, and then we have our external anal sphincter. Now we're going to start off strong. These muscles are for sexual function. we're gonna go right into it, okay? These muscles have to be able to relax and contract for the female to get to an orgasm. It has to happen. If we don't have that function, it makes it really hard to have good sex, to have an orgasm, and it be desirable and something you want to reach. So these muscles here, they have to relax enough early on in sex to be able to kind of engorge with blood, so they have to expand. And then later on in sex, for us to reach our orgasm, they have to be able to contract. So talk about starting off strong with this speech, huh? Okay, so now when we go into the intermediate layer, we're talking more about stability and support. Here we have this lighter blue, that's called our perineal membrane. It's mostly consisted of fibrous connective tissue. It's not necessarily a muscle, and it's really just for support. Now the other muscles that we have here are a lot of sphincters. So when we talked about sphincters, they really are circular muscles that open and close depending on what we need to do, whether it's the urethra, the vagina, or the rectum. And same thing, it helps you be able to go to the bathroom or hold it if you need to. So here we have the perineal membrane. We have a deep transverse perineal muscle. We have a sphincter urethrovaginalis that encompasses the urethra and the vaginal opening. And then we have a compressor urethra that just helps to compress it and hold it closed. Now for our third layer, that's our deep layer. These are our big pelvic floor muscles, and you can see them through the top there. And then if you had the other layers of the muscles, like on that model there, you wouldn't be able to see those deeper muscles. Now you have a group called the levator ani group, which is really what it does. It elevates the pelvic floor. It consists of these muscles, which is very tedious to say, so I'll say it anyways. But you have pubococcygeus, iliococcygeus, coccygeus, and puborectalis. Really, these are the ones that are going to help you get that pelvic floor lift and provide a lot of strength and stability here. Now, the different one here is the puborectalis. That's the only one that doesn't come all the way back to the coccyx. It actually just wraps around the rectum and then back to the pubic bone. This one's really important when we start talking about constipation because it can compress the rectum. And so there are some positionings and some therapies that we can do to relieve that.
You can't help it.
I know. I'm like over here seeing you laugh. Now, how is it directly connected to the hip? And that's through the muscles of the pelvic wall, which are actually hip rotators. So I feel like everyone's heard of the piriformis, correct? It's a hip external rotator. It sits underneath the glutes. You get a little bit of sciatica if it's too tight. We've all heard of this one. Now, the other one is called our obturator internus. It's one of our deep hip external rotators, and it actually inserts right onto the pelvic floor. So here on the either side, we have the pelvic floor right through the middle. We have our obturator internus on the sides and the piriformis more towards the back. And I'll let y'all take a picture of that if you want to. But it just goes to show more that we have to treat the hip if we're gonna get a full picture treatment, okay? All right, now the last thing anatomy-wise that we need to talk about, because we've talked about bones, now we've talked about muscles, we got to talk about the nerve innervation to these muscles, because this is what tells our muscles to turn off and turn on, okay, and it gives us all the sensory information that we need as well. Now the main nerve for the pelvic floor is called our pudendal nerve. It actually starts from our S2 to S4 sacral segments, so that's an area that we have to treat as well when we start talking about treating the muscles. It wraps around and underneath into the pelvic floor and it innervates all of the vulvar area and the pelvic floor muscles themselves, so sensory and motor. It branches off into the peroneal nerve, that branches off into here. It branches off into the nerve of the clitoris, and we all know why that one's important. So it's very, very important that we have adequate nerve function too, not just adequate muscle function. They have to work together.
All right, now that we understand what the pelvic floor is, all of its structures, what are its functions? The pelvic floor consists of the opening and closing of the front and the back. It plays a key role in sexual function, of urine flow. It supports pelvic organs, including the rectum, the vagina, uterus, and that is very important. The pelvic floor needs to support these, but it also can't be too rigid so that these organs can function correctly. It provides postural support and stability, coordinates with breathing and trunk control, which we'll talk about in a second, and assists with lymphatic flow. So how is it connected to the rest of the body? If we want to think of our trunk as a soda can, around the soda can is our deep belly muscles, and then on top of that soda can is our diaphragm, which is the muscle that moves when we're breathing, and under the soda can, that's our pelvic floor. These need to work together and coordinate together for the pelvic floor to function properly. So when we take a big inhale, our diaphragm is going to lower, and at the same time our pelvic floor will also lower and relax. And then as we take an exhale, we're going to come up, both the diaphragm and the pelvic floor will lift and tighten. And this is very important in day-to-day life when we're lifting something. If we were to sneeze or cough or laugh, those need to work together harmoniously and to prevent leakage, to prevent other things that we're going to be talking about.
Let's talk about pelvic floor dysfunction. So that's how we would optimally like the pelvic floor and the trunk and everything to work together. With those, we shouldn't be having any symptoms. Now, if something goes awry there, this is when all these problems start to come up. So we're talking about urinary incontinence, pelvic pain, prolapse, all of the main diagnoses that we'll be talking about today. So this just goes to show there are different symptoms that can come up and different diagnoses that come and are encompassed in this. Now the first one is going to be urinary incontinence, and that is going to be leakage. We're going to talk about two main types of urinary incontinence and the common symptoms that come with those so that we can better identify what we're having and the symptoms we're having, and then we'll address some treatments as well. So the first one we're going to talk about is leakage when we cough, when we sneeze, jumping, exercising. Think about those symptoms if any of you have any of those. This is called stress incontinence. When we have stress incontinence, when we're jumping, when we're sneezing, we're building up a lot of pressure within the trunk. So we're doing a big inhale, especially when we have to sneeze. A big inhale, we're holding it and we're bearing down. When we do that, we put a lot of pressure down onto the bladder, which then puts extra pressure on the pelvic floor. Now, when leakage starts to come in is when the pelvic floor cannot support that pressure. So there's too much pressure pushing down onto the pelvic floor, and then that's when urine starts to leak out. This is not always due to pelvic floor weakness. It can be also due to pelvic floor tension. So I know commonly it's mistaken as, oh, I'm leaking, my pelvic floor must be weak. That's not always the case. So when we think about having muscle tension, if it's so tight that we can't engage it all the way, it's still, a tight muscle is still a weak muscle in a sense because we're not fully able to contract that muscle to its capabilities. And that's where we have the leakage. There's no way to hold it in at that point. So when we talk about treatment focuses, can we address the pelvic floor dysfunction, whether it's tense or if it's weak, and making sure we're doing the right things to address those? Can we address the pressure management? So is our breath connected to our pelvic floor? Is that happening simultaneously like it's supposed to? Can we reduce the amount of pressure when we're going through some of these activities? And then, like we said, re-educate those muscles to do what they're supposed to do and coordinate that.
A big part of understanding our pelvic floor, being able to strengthen it, and a very important part of stress incontinence is understanding that diaphragmatic breathing we've been kind of touching on. These need to work together in order for everything to go right. So basically, we need to learn how to relax and when to engage, because if we don't have that coordination, we'll start to recruit other muscles, stress other muscles, and this could, we also need this for our core control, and we practice this in therapy, and once we are able to master this, this will help us during our treatment with stretching, with strengthening, and we'll go over that soon.
All right. Now the second type of incontinence that we are going to talk about is when we have leakage, when we have the urge to pee. So that's like on our way to the toilet, that's seeing a restroom sign, that's running water, any of the, I mean, it happens. You're like, I wasn't even thinking about peeing and now I'm peeing all over myself. What the heck is going on? So if you have any of that, that's called urge incontinence. That's where we have what's called like an overactive bladder. So the muscles of the bladder are activating too soon whenever the bladder isn't even full. And at that point, it's not communicating with the pelvic floor, and the pelvic floor isn't tightening like it's supposed to, so then you just have full-on leakage. Now, optimally, whenever the bladder is filling, those detrusor muscles or the bladder muscles should relax and expand to let the bladder fill. At the same time, the pelvic floor muscles should contract to be able to hold. So the deep pelvic floor muscles and all those sphincters, those tiny circular muscles, all of those should stay tight as the bladder is filling. Now when we go to pee, the pelvic floor muscles should relax, and then those detrusor muscles should start to compress, and we should have a natural flow of urine. It shouldn't be bearing it down or anything like that, because that can cause more problems. So when we talk about treatment focuses, can we avoid some bad voiding habits? So this is, are we hovering while we're trying to pee? We're like, can we do a squat? How strong am I? Can I sit here and hover while I'm peeing? Forcing pee out, straining while we're trying to go to the bathroom, doing Kegels while we're peeing. That is bad, bad, bad. Don't do it. That's the first thing I tell patients with urgent incontinence. Like, don't stop your flow of urine. Don't do it. Because the bladder and the pelvic floor have a direct communication there. So if you start to play with that communication that's not normal, then you start to have dysfunction there, and they don't work together at that point. Now, what we can do here also is avoid some bladder irritants. So this is going to be alcohol, coffee, chocolate, and you're like, boo. Who wants to give up that stuff? But just things that we can cut back on so that we don't have extra irritation to the bladder. One thing too that we can do is address the overactivity of the bladder and the underactivity of the pelvic floor. We can do this through dry needling. So all my patients that I see out here, you're very, you know the dry needling. You understand it, you felt it, you know what it's all about. What's great about this is we can actually hook it up to electrical stimulation with the right charge that we need. So if we have something that's overactive, we can actually send a negative charge to downregulate it or get it to calm down. Vice versa, you can send a positive charge to it and upregulate it, causing it to activate more. So that's a great thing where we get a little bit of nerve re-education, or we call it nerve modulation, and it's a great treatment for this urgent incontinence. And then, like I said, upregulating the pelvic floor muscles so they can support the bladder and they hold long enough, have the endurance to hold long enough to get you to the toilet. Now, the one pelvic floor dysfunction that is truly like soft tissue muscle laxity. And when I say laxity, just like loosey-goosey. It's too loose, it's not activating enough, and that's pelvic organ prolapse. So symptoms of this are like vaginal heaviness, you feel a bulging, you have a hard time going to the bathroom, whether that's voiding or a bowel movement. You can have some excess discharge or bleeding. There's 3 different types of pelvic organ prolapses, and I'm going to come down here so I can point them out too. Up and in, up and in. All right. So the 3 pelvic organs that can prolapse into the vaginal canal or kind of descend into the vaginal canal is the bladder, the rectum, and the uterus. Or it would be, if you had a hysterectomy, just the top of the vagina would fall down. So whenever you see a prolapse or any kind of bulging outside of the vagina, you're not seeing these organs coming out of you. So don't worry. What you're seeing is actually the vaginal wall where it's collapsed and fallen into the opening. So if you see normal alignment here, the bladder sits in the front, you have the uterus above the vaginal canal here, and then you have the rectum in the back. When we start to see a bladder prolapse, the anterior wall of the vaginal canal has been compromised, and there we have the falling of the bladder into the vaginal canal. Now on the opposite side of that, we have the posterior wall with the rectal prolapse here. So the posterior wall of the vaginal canal has been compromised, or it's lax, and so then you start to have the prolapse here. Now here we go, uterine prolapse is where you just have a true descent of the vagina. Okay. Like I said, there are some the symptoms there. When we start seeing excess discharge or bleeding, that's usually whenever the vaginal wall starts to come completely out. So we are talking about higher grades of prolapse, and that internal tissue is starting to be exposed to external environment. We don't want that because it's not built for that. It's supposed to be inside of you. Treatments for this, a lot of the times we want to start with reducing the prolapse. So this is getting into some positions where we get the hips higher than the shoulders and let gravity do the work. Let it fall back into the vaginal canal and where it's supposed to be sitting. This can be laying on your back with pillows under the hips and those kind of things. So a lot of times we'll start there. Can we get there for 20-30 minutes at a time? Just let all of that reduce. And then we come behind it and add pelvic floor strengthening to keep it where it's supposed to be.
So how can we strengthen all of that, especially treating a prolapse? Usually when I've gotten like fillers from other patients, what's pelvic floor, do you know what that is? They just say like, oh yeah, Kegels, yeah, just do the Kegels. And Kegels are very important to understand how to do, and honestly probably most are not even performing them correctly. So that's where we come in and show you how to perform that correctly. But as we've talked about, the pelvic floor is connected to a lot of other parts of our body, so we can't neglect our hips, we can't neglect the low back, and even our abdominals are going to play a huge role in that. So when I'm getting patients in the gym, we're not just doing Kegels, we're going to be doing some hip rotator stuff. Remember that piriformis muscle, that's very important to make sure we're strengthening. We're doing bridges, planks, and there's a lot of studies that have been shown that planks, leg raises, bridges can be just as effective as Kegels, or even more effective than Kegels, because like I said, most probably aren't even performing them correctly, or maybe we haven't learned how to recruit those muscles correctly yet. So this is a great way to start.
All right. We're about to put you to the test. Sorry. Before we play this video on the next slide that's going to test out how good can you do a Kegel, let's talk about what it is and how to do it. So when we're assessing pelvic floor strength and coordination, what we first feel for is a cylindrical squeeze, and then there is a palpable lift as well. So most of the time when we tell someone to do a Kegel, they squeeze their butt. I'm like, nope, nothing happened there. Sorry. That was not it, okay? No, like, did I do it? No, okay. So really what we're looking for is you should not be able to know when you're doing a Kegel. So you did not know I've been doing Kegels this whole time. Shouldn't be able to tell, because you don't want all those accessory muscles to turn on, which are your hip adductors, your inner thigh, your glutes, your abdominals. You really want to isolate the pelvic floor to get that squeeze. So we use this a lot we'll do the squeeze and a lift. Squeeze and a lift. So let's practice, okay? So this video that we have on the next slide.
Hip movements, no back movements.
Yeah. So if you start lifting up and down on the chair, you just squeezing your butt.
You're out.
So
Forget to breathe.
Yes, and don't forget to breathe.
So you'll notice too with this video that we're going to show you, there's different ways that we want to be able to activate the pelvic floor. We want good, strong contractions. We want a contraction with a long hold, so we're working endurance. And how quickly can we turn it on and off? Because we need those fast twitch muscles, especially when we're talking going back to stress incontinence. How fast can I squeeze my pelvic floor so I don't cough and pee? Those kind of things. And that's where it becomes very important that we are able to do these things. So do we want to do a couple practice before I turn the video on, or you want to go for it?
Let's go for it. All right.
Ready?
Y'all got this.
All right, let's go.
Time to squeeze, squeeze, release, squeeze, release, squeeze, release. Keep going, squeeze, release. Hold for 4, 3, 2, 1. Let go completely. Pulse for 3, 1, off, 2, off, 3, off. Hold for 7, 6, 5, 4. Keep breathing. 3, 2, 1. Release completely. Squeeze again. Hold it. 8, 7, 6, 5. Keep breathing. 4, 3, 2, 1. Release completely. 5 quick ones. 1 off, 2 off, 3 off, 4 off, 5 off, off. Hold for 10, 9, 8, 7. Keep breathing. 6, 5. Lift tighter. 4, 3, 2. Hold it. 1. Let go. 4 slow 1.
All right. I think y'all got the idea. All right, how's everyone doing so far?
What is her name?
Oh, God.
I'll bring it back up. She's great because she has an accent too, and I was like, it's always better with an accent. I don't know. But how are we all doing? Do y'all need a break? Do we need some water, bathrooms? Are we okay? Okay. All right, now we're gonna make a switch. So when we talk about leakage and prolapse, for the most part, but not always, we're talking about an underactivity of the pelvic floor. When we get into pelvic floor pain, we see a very common hyperactivity or pelvic floor tension that is associated with it. Now, pelvic floor pain is very complex and complicated in the sense that there's a lot of systems that hang out around here and can contribute to some referred pain to the region. So trying to figure out, is it coming from the bladder? Is it pelvic floor dysfunction? Is it nerve? It makes it kind of hard to diagnose, but what we have found is that the common findings are pelvic floor tenderness around the inner thighs, the abdominals, a lot of tenderness around the glutes and the lower back, difficulty even activating or relaxing the pelvic floor. Usually we can see an elevated resting tone, so something that we look for is that perineal body, which sits between the vagina and the anus. You'll actually see it really elevated where it should be fairly flat. And so it'll kind of pucker up a little bit where you can't see it very well, and that's an elevated resting tone. Other things that you'll see is the hips and lower back aren't moving well. You'll have a lot of restrictions there, especially with rotation. And then we see a pelvic asymmetry, whether that's one side being hiked up, are we rotated forward there, things like that.
So like she was saying, there can be a lot of different diagnoses. So this just goes to show, again, how complex the pelvic floor is. And it's important, I find, to get evaluated by a professional if we're having any of those symptoms she was talking about. Because unfortunately, a lot of us will live without having a diagnosis and just think like, okay, well, maybe this is normal, or maybe we'll be misdiagnosed. But luckily for us, we happen to know and can determine what is really going on and target that specifically for you and be able to treat that.
All right, so the first two diagnoses that we'll talk about is vaginismus and vulvodynia. These are very closely related because they happen within the same area. So when we talk about the vulva in general, we're talking about all the external genitalia as an area as a whole. So as you can see on the picture there, we have the vaginal opening. On either side we have two sets of labia, or also translate to lips. So we have our labia minora towards the inside and our labia majora on the outside. The majora is larger. It usually has the pubic hair growing on it, whereas the labia minora does not. Now at the apex we have our clitoris, and the prepuce, or what we call the clitoral hood, that covers and overlaps it. We have our perineal body that sits between the vaginal opening and the anal opening. But this is what we're talking about when we talk about the vulva. It's the area as a whole. Now with vaginismus, this is pain with insertion, and that doesn't always mean pain with sex. This can be with a tampon, this can be insertion of a finger, it can be a penis, or it can even be when you're going to your gyno and getting a speculum inserted for the cervical exams. It can be any kind of insertion. Now it could be at the opening, or it could be deep penetration as well. So it kind of encompasses everything when we're talking about insertion into the vaginal canal. Now vulvodynia is pain in or around the vulvar area. So that could be the whole area, it could be just the labia majora, it could just be around the perineal body, but it does encompass all of those pain diagnoses. Like I said, all of this is usually accompanied with pelvic floor tension. So the first thing that we want to start doing is opening everything up. We want to start relaxation techniques. We want to do deep breathing. We want to start to address those trigger points that we find, and dry needling is very effective when we talk about those things. One thing that we do use also is vaginal wands and dilators, and I'll show you a little bit of that on the next slide. One thing that most people don't know that we do is internal releases. So we can actually go into the vaginal canal and release some of those deeper pelvic floor muscles that you can't reach on the exterior, and that's where we get a lot of good benefits and relief of symptoms. So this is some of the tools that we can use. So on the top left-hand corner, that's a pelvic wand. What you do is insert that into the vaginal canal, and it's curved so you can kind of do a full scope of the whole pelvic floor there. This is where you can find those tender spots, those trigger points, apply pressure, and help to release those trigger points. There's a larger and a smaller end depending on comfort. Now, when it comes to vaginismus, the pain with penetration or insertion, we start to talk about vaginal dilators. They start very, very small. That way we can start very small and let the vaginal canal adapt to the size difference. So here you can see the bottom left corner, and you can start to progress up. That way we give the body time to adapt around it. It can lengthen on its own time. We do some deep breathing with those things. It's not something that we're inserting while we're trying to do activities. It's like end of the day, we're winding down, we're getting ready for bed kind of thing. Now the other thing that I have had a patient use and have had really great success with is the O-nut rings. This is the Pelvic, I think it's called the Pelvic Company. They make all these great products. These are silicone rings that the man can put on his penis to reduce the penetration. So this is where we can have women that they can still have comfortable sex while working on the tension that they have by reducing the amount of penetration so that they can go and have an orgasm and have comfortable sex and not have pain with that as we start to treat. Now, right to the right of that, that's called a kiwi. It's like, I guess it doesn't really look like a kiwi, but whatever. This one's great because it's very minimal penetration. So you can see on the bottom, there's a little piece that sticks out. What's also great is that it vibrates. So this is really good for trying to loosen up some of the muscles. So you can use it internally. You can use it to vibrate and relax some of the inner thighs, the glutes, those kind of things. And like I said, minimal invasion. So this is a great start when we're talking about someone that has high pain levels, especially around these areas, because we can start to ease into some of these things. Now, we didn't talk about rectal pain, and we're not going to talk about it today, but if we're talking about rectal pain and constipation, there are rectal dilators as well. And so that's always something that we can address and talk about if needed. Now, the two other diagnoses that we talk about pain-wise is pudendal neuralgia and coccydynia. Pudendal neuralgia, remember our pudendal nerve, it starts at the sacral segments S2 to 4, wraps underneath and innervates sensory and motor function to the pelvic floor. It branches off into the perineal nerves and gives us all the sensation there. Now, whenever it wraps around, it does become very superficial there as it comes in through in between the ischial tuberosities, so it is easily injured. So this can be riding a skinny bike seat, a saddle. This can be a fall or childbirth. So very easily injured. Now, how we decipher whether it's muscle pain or nerve pain usually feels more like burning, shooting, numbness and tingling. It radiates, those kind of things. So when we start hearing symptoms like that, we're like, okay, I think we need to start looking at nerve and nerve function rather than are the muscles causing this pain or being the pain generator. It affects a lot of areas because it can be injured at any point on the nerve, and it doesn't mean that it's going to hurt the whole tract of the nerve either. So we got to look at all the way from the sacrum to the front to the pubic bone. Now, tailbone pain or coccydynia usually happens with a fall. You fall right on your tailbone. How many people know someone that fell and broke their tailbone? So it happens. When we have that happen, we have an anterior and side-to-side deviation, especially if we have a fracture. Now, it's not always a fracture, but we can have some movement there. It can be very hypermobile after a hard fall, but it's not always the case. Now, what we usually see with this is the glutes take off. They're like, I gotta fix this, I gotta figure out where this needs to go. So usually it's like one-sided, especially if we have a side-to-side deviation of the coccyx or that tailbone. The other side, that glute, will tighten up so much to try and fix it and realign it. What we can do with this is making sure we're not sacral sitting, so that slouch sitting, because it'll further push that tailbone forward where we don't want it to be, because we think we got connective tissue there, we have the pelvic floor muscles there, we have the nerves there. We don't want to impinge on that. So really we want to start to, can we fix the deviation of the tailbone? Can we loosen up everything around that and get it right back where it needs to be?
So like Chloe's been talking about, a big part of treatment over here is that we're going to need to be working on stretching and mobilizing everything. And of course we need to relax the pelvic floor, but also our hips, our back, our abdominals. We use massage balls. We use a lot of different techniques. Right here, this lady, she's doing what's called the happy baby pose. It's a yoga pose. I love to incorporate yoga into my treatment because that way we can kind of get into a good position and just work on that deep breathing technique and just let everything relax. And she's actually doing a great job of this. She's opening up her pelvic floor, opening up the hips and the low back as well. So she's getting an all-for-one stretch right there. So you'll see in treatment, we'll work in the room, we'll do some treatment there, but then we also will work on all the other muscles as well, just stretching and mobilizing everything. That way those muscles can start to get more elongated, and that really helps with the pain. So next we're going to get into pregnancy and postpartum, which of course is also a big part of pelvic floor therapy. 46% of pregnant women have reported at least one pelvic floor symptom. Urinary incontinence prevalency is between 18 and 75%. You'll see a lot of big percentages here, and that's just because it depends on when this was reported. Some of this could have been reported by a group of people in their first trimester versus their third trimester, people during their first pregnancy versus their third pregnancy. There's going to be a big delineation, but still you can see that urinary incontinence is huge. Pelvic organ prolapse, everything has kind of loosened up now and is unfortunately falling, and so 10 to 29%. And then diastasis recti, which I'll also explain, 30 to 60% in the postpartum period. So the importance of pelvic floor therapy. First of all, we can reduce urinary incontinence by 50% in the prenatal period, and then by 35% in the postnatal period, just by exercising and doing pelvic floor training. Studies show that 24% of women, when they were initially taught a Kegel, could not perform correctly, and then 23% of those that said, "Oh yeah, I do Kegels," weren't performing them correctly. So that's why therapy is also another reason to come. We'll teach you how. And this is a huge number. 90% of non-exercising pregnant women developed diastasis recti, while only 12.5% developed that were not exercising.
So let's talk about a little bit of some common diagnoses that come with pregnancy. So we're thinking there's a lot of bodily changes that are happening as we're going through the different trimesters of pregnancy. The belly is having to expand, the abdominals are having to expand, the pelvis has to widen to get ready for delivery and birth. The pelvic floor has to lengthen towards the later stages. So there's a lot of things that can start to happen and shift that can cause some of these dysfunctions, like ones we've talked about, the leakage, the pain, prolapse, things like that. Ones that are a little bit more specific to pregnancy is the diastasis recti, round ligament pain, pubic symphysis pain. So we got to think there's a main hormone called relaxin that's being released while we're pregnant. That makes everything loosey-goosey. Our joints, our muscles, our connective tissue, because all we have to do is expand at that point. So how can we prevent some of those things and make the birthing process, the pregnancy process, the postpartum process as best as we can?
So diastasis recti, like Chloe said, relaxin is surging in the pregnant mama's body. This is going to soften the connective tissue called the linea alba, where our left and right abdominal muscles will start to separate. This doesn't mean the muscle is being torn, it just means it's separating, causing a pooch or a bulge. as you'll see at the bottom picture there. And this can cause low back pain, constipation, and core control, because now we can't contract those muscles properly, and then we're not able to bear down to perform a bowel movement. And we can actually be causing more issues if we're not knowing the correct core exercises to perform while pregnant. So that's something I've actually been working with a new pregnant mama on, the correct things to perform, so she can still keep a good core, but we're not stressing that.
And I think Jordan is a great example of this, and I'll let her tell her story, but I mean, she was like a top tier athlete while she was pregnant. She was lifting heavy weights. She was doing everything that you wouldn't think you would do while pregnant, because there's this stigma or this misconception of, oh, you're pregnant, you can't do that. You can't exercise. You can't lift that. When actually it prevents a lot of these things and a lot of these problems that can occur if you don't do these things. If you don't exercise, it actually can cause a higher percentage of, or likeliness of happening. So I'll let you tell your story.
I want to toot my own horn, but no, I've been through 2 pregnancies, and I love to run. I never stopped running. I love to lift heavy weights. I never stopped that. I continued my workouts, and I never experienced any urinary incontinence, and never, maybe very, very, very little diastasis recti, and no tearing, which that's another big one.
That's a very big one.
I incorporated, of course, with the running and the heavy lifting, I incorporated a lot of yoga, a lot of stretching, perineal massages to loosen that area and really prepare for labor and delivery. And I mean, and I didn't even know all of this at the time. I was just doing what I've been taught my whole life. And when I found out people were tearing from front to back and, you know, having these belly bulges after birth, I was like, oh God, thank God. I didn't experience any of that. So, I mean, I think the statistics show that, you know, this is worthwhile.
All right, so when we talk about treatment during pregnancy, we have 3 phases, just kind of like we have the 3 trimesters of pregnancy. The first trimester, and honestly even before finding out that you're pregnant or trying to get pregnant, we need to create a great foundation. So how strong can we get the core? How strong can we get the pelvic floor? Are we contracting all of these things adequately? Are they engaging all the way? So really when we're focusing on the first phase, we're focusing on, can we get everything as strong as possible, and can we make sure we're doing everything correctly? When we have that, once we get into the second trimester, we can start to build upon that and really start to adapt to the structural changes that are happening. So the belly expanding, the pelvis expanding, those kind of things. And can we keep that strength throughout the second trimester to start preventing some leakage as the baby grows? And this will also decrease all the likelihood of things happening postpartum. Now, when we get into the third trimester, we kind of switch paces. We go from strengthening in the first 2 trimesters to how much can we lengthen the pelvic floor in the third trimester. This is truly for delivery and birth. Now, there are some things like the breathing techniques that we talk about in the beginning, we flip that as well. So normally what we would do, or optimally what we would do, is when we inhale, we want the pelvic floor to relax, and then exhale, the pelvic floor to contract. In the third trimester, we flip that completely around. I know a lot of people have talked about, does everyone know what I'm talking about when I say purple pushing whenever we're delivering? So holding the breath while we're trying to push the baby out instead of breathing through it. A lot of people call that purple pushing because you're holding your breath for so long trying to get the biggest push that you can to get the baby out as fast as you can, which I get it. I don't have any children, but I get it. I get all. But actually what we want to do is be able to exhale while we're trying to push. So that's why we switch that training. So then whenever we're preparing for birth, we want to do the push on the exhale so that we can still have our breath as we're going through labor and delivery. Now another thing is you don't have to just lay on your back to push the baby out. There are different positions that are more optimal at opening the pelvis and getting the pelvic floor in a better position so that we can prevent some tearing. So this is squatting. This is going on hands and knees. Can we internally rotate the hips so that we can flare those ischial tuberosities and open up the bottom opening more? There's a bunch of different ones that you can try out, and it's honestly what you're most comfortable with. And even if that is laying on your back, that's what you should do. Do whatever is comfortable for you and what you feel the best with whenever you go into the delivery process.
So when can we start during postpartum? Like, when can we seek an evaluation? When can we go to PT? The easiest answer is as soon as possible. We don't need to wait for that magic 6 weeks when the doctor gives clearance for activities. We can start working on any like low back pain, pelvic pain, any diastasis recti. We can start working on some of the breathing techniques and bracing. And then when, and as I mentioned earlier as well, doing these kind of treatments will decrease urinary incontinence by 35%. And you know, it's also, you know, there are many studies that show that regular walking, regular exercise after having a baby will decrease postpartum depression tremendously. And I mean, I commend any mom who's going to take the time for themselves. It can be so exciting to bring a new life in, and everybody's, you know, so excited to see this new baby, but we need to also recover and take time for yourself. And so come see us, come take time for yourself to recover, because your body just went through a lot. And then once we do get that 6-week clearance, or whenever that may be, we can start to incorporate low impact cardio and perform any internal work if needed.
All right, so what sets pelvic floor therapy at Acadiana Pain apart from other places? And that's our regenerative surfaces. Now, the biggest one that I'm the most excited about, and we recently got, and I've had patients, she's already waving at me, she's like, I can't wait to talk about it.
Right now.
So the big one that we just got and have already seen some significant improvements in patient symptoms with is our pelvic floor chair. It's a high frequency electromagnetic therapy that causes super maximal contractions to the pelvic floor. And you're like, what the heck does that even mean? Pretty much all it does is it sends stimulation into the pelvic floor to cause a super maximal contraction, so beyond your maximal capability. It does long endurance holds, it does multiple contractions in a row, it does fast twitch, so it's really full encompassing on everything that we need the pelvic floor to do for any of these diagnoses that we've talked about. One of the studies that I pulled up, this is for urinary incontinence and prolapse. After 10 sessions, they're 20 to 30 minutes long, you do them 2 to 3 times a week based on your schedule. After 10 sessions, they had greater than 50% of reduction in symptoms, and that's amazing. I mean, you just don't see that a lot anywhere else. Now, what's great about this is it's high volume training, so it's like an extra session of strengthening. We get about 11,000 contractions in a 20 to 30 minute session. So if you can think about doing 11,000 Kegels in 20 minutes, if you get that on your own, come let me know, I'll give you a prize. We get very rapid results, so 50% of reduction or more in 10 sessions, but you can actually feel a difference in 1 to 2 sessions. And I have a couple patients in here, talk to them, they will tell you the same exact thing. It's really great for incontinence relief. It is good for prolapse as well, because we can start to reduce the vaginal area, especially if we have some tearing and postpartum where we have an opening of the vaginal canal, which makes us a little bit more whatever. Words. Words are hard, okay? More likely to have a prolapse. And also there's no downtime here, so you're not super sore afterwards. You may have a little bit of soreness. You're fully clothed, it's non-invasive. You sit on it like you would a regular chair and you let it do the work. It's a great, fantastic therapy.
Another service that we offer is laser therapy. This is a photobiomodulation that's that stimulates cellular activity. What are all those big words, Jordan? Use English. It basically just means that red light is taken in a very concentrated area and able to penetrate up to 10 centimeters. So red light over that area, we're able to target any damaged tissue. It will help accelerate that healing process. It reduces pain and inflammation. It improves vascular and nerve function. And we use this for different things, like with menopause, if you have vaginal dryness or pain during sex. There's studies that show it helps with vulvodynia and can be really great for pelvic health in general.
And it is really great for pelvic health in general because of how deep some of these structures are, and because we can get this deep penetration here, we can start to reach some of those muscles that you wouldn't otherwise be able to when we're talking about accelerated regenerative healing. Now, the other one that I want to talk about, and I'm not going to go super in depth with peptides, but pretty much peptides are our building blocks for all the tissues in our body. These are naturally occurring, our bodies make them themselves, but when we're going through a healing process, can we give it an extra boost? So what we usually do with this is we combine it with some dry needling and laser therapy, and I'll discuss how that works. So if we have peptides as our building blocks, the dry needling gives us the roadmap for the peptides. So the peptides are like, okay, I know exactly where I need to go and what I need to be doing. Now we add on the laser because laser accelerates cellular activity and energy and reproduction. So if you put all that together, you have a great combination to let your body naturally heal, because our bodies have that capability, but let's give it some extra help, you know? And that's what sets us apart from other places. We can do these accelerated regenerative healing processes and really speed up everything. So what does an evaluation look like when you come in? So we do a very in-depth history, and that's so that we don't miss anything, especially when it comes to pelvic pain. So we're talking about previous deliveries. Were they vaginal? Were they C-section? Do we have any other injuries around the lumbar spine and the hips? So it really is full encompassing. We look at the rib cage, make sure we're breathing properly, those kind of things. Now, one thing that we do is an external perineal assessment. So we're looking at the skin, because sometimes you can have what's called like lichen sclerosis that can cause pain at the skin around the vulva. So we're looking for any kind of skin adhesions there. We'll have you perform a pelvic floor lift and a bulge to make sure that there's movement happening. And then we'll do some palpation, and here we're looking more so for some trigger points. Now, another thing, and I kind of mentioned this earlier, another thing that we do that most people don't know that we do is an internal pelvic exam. So here we can palpate the deep muscles of the pelvic floor. We can get to the obturator internus and that piriformis from the inside, and it really tells us what's really going on. Because if I just look at it, look at the vulva, look at the external, and don't touch the tissues, I don't go inside to touch the ones that I can't even see, then how am I going to be able to treat you the most properly? That would be like saying, hey, my shoulder's hurting, and I don't touch your shoulder. That doesn't sound very great. I don't know if I would go back to me after that. So it's very, very important. Now, is it 100% necessary if it's something that you're unsure of? We don't have to do it on the first visit. It's something we can work on a few things. We can get a couple weeks in, but then if we're still not seeing some results, then it's like, okay, we got to have a hard conversation. It's time to get into some internal examination because we need to see what's really going on. All right, tips and tricks. This is going to be kind of an overview and then some tips and tricks as well.
All right, as far as with the bladder and leakage, we don't want to practice just in case peeing. We don't want to hover over the toilet. No Kegels during peeing. Again, this is just creating bad habits for our bladder. Our bladder should be relaxing during that time, and so now we've just confused everything if we're doing that. Voiding should last approximately 10 seconds. If that's not happening, maybe we're either not relaxing enough, we're not emptying the bladder completely. Bladder and leakage issues are not always due to pelvic floor weakness. If I contracted my muscle all the way here and I said, okay, contract more, go further, I can't. So if our pelvic floor is tight and we need to void, we can't contract any more than that. We need to be able to relax it as well. And then avoiding any bladder irritants such as alcohol, coffee, and citrus foods. For bowel habits, I'm sure many of you have heard of the squatty potty. That helps to open up the low back and the hips, get us in a good relaxed position. Working on that deep breathing so that we can bear down well. And working on the pelvic floor relaxation, doing yoga, making sure we're getting really good breathing in through our nose, out through our mouth, and just letting things happen naturally.
Tips for vaginal health. One big thing is routine vulva checks. We need to be checking that area and those tissues. I mean, honestly, at least monthly. We need to be knowing what's going on down there so that it can stay healthy and we know that it is. Because if we're not even checking it, we don't even know what's going on down there, we have no idea what could be happening. Another one is vaginal estrogen, and this is going to be a big one for my postmenopausal ladies. Vaginal estrogen has been shown to improve vaginal dryness, muscle atrophy of the pelvic floor. It helps us increase a lot of lubrication, prevents pain with sex, those kind of things. Now, this is just local estrogen. This is not the hormone replacement therapy. That's more systemic. When we start talking about that, we're talking about, can we keep our bones healthy, our muscles healthy? Can we build muscle after all of our hormones have been depleted post-menopause? And then there's a lot of studies coming out too that it's really good for our brain health, preventing dementia, Alzheimer's, those kind of things. So completely different. When we're talking about true just vaginal health, the estradiol, those kind of things, the vaginal estrogen is very good at preventing some of those symptoms and alleviating them. But if we want overall systemic health, you would have to do the systemic hormone replacement therapy. Women's probiotic is very good for vaginal health. So our vaginas, they have a bacteria just like our gut has a bacteria. You have good and bad. The good bacteria for the vaginal canal is our lactobacillus bacteria. So whenever we're looking at a good women's probiotic, we just need to make sure that they have multiple variations of that lactobacillus strain. And then that'll keep the pH well, will reduce infections, those kind of things. We want cotton breathable underwear. Same thing, we don't want that area to be too moist because that's where infections start to fester. And then we want to clean the area with just water. We don't want fragrant soap or anything like that because it can irritate the skin. And then pregnancy and postpartum, you can exercise and lift while you're pregnant. We just have to be very intentional on how we do it. It is not unsafe. It actually prevents a lot of the problems that can occur after delivery. So that's just, we gotta, if anything, take that away for pregnancy and postpartum. Still start pelvic floor therapy as soon as possible. When you find out you're pregnant, or if you don't do it beforehand, as soon as you're postpartum. We want to do perineal massages and relaxation in the third trimester. And I say perineal massages because that's a big one when we talk about preventing tearing. And then there are many different birthing positions. Just know that there's a lot of different ways you can do this. There's not just a one size fits all. Yeah. All right, do we have any questions? All right, Ms. Petra.
You spoke about needling during pelvic therapy.
Yes.
Where exactly?
Okay. Fair question, fair question. The pelvic floor needling is usually through the glutes.
Can you repeat the question?
Oh, yeah. So how do we do needling for the pelvic floor? Usually it's through and around the sacrum, so we can reach some of those deep pelvic floor muscles. I don't know where our little thing is. Oh, I see it now. What's great about needling is that we can reach these structures through the glutes to be able to reach into there. So here we have the deep pelvic floor muscles inserting onto the coccyx there. We can actually come through that glute max into some of these muscles and stimulate them. Now we do this also with the pudendal nerve. We can follow its track as it comes down and then curves forward. And we have, I do this with my patients. We hook it up to stim. You can feel the sensation into the vulvar area, so you know you're on it. But that's how we get to the pelvic floor muscles with the dry needling. A lot of it is through the backside, through those glutes. Any other questions? Yes, ma'am.
How long do the results last? Is this like permanent? Is this ongoing?
So that
Is that dependent?
it depends. So just like with anything that we would treat here, if you keep up with what we call homework, so if you stay active, you do your exercises regularly, we make sure we keep the mobility and range that we've gained, then they should last forever. Now that's if you keep up with those things and we're doing everything that we need to do to prevent them from coming back. So what we do at Acadiana Pain is instead of doing, let's do 2 times a week for 6 weeks and then you're good to go. We don't do that here. And you can tell from, you can ask our other patients, they know how it rolls. But usually once we start getting to where we're in the pain relief, then we start to talk about, okay, how's everything moving and how strong are we? So we're talking about strength and mobility. From there, it's like, can we optimize that into all of our daily activities and everything that we want to get back to? Because that's what it's all about. It's like, can I go play with my children? Can I run down the road? Can I do all these things that I love to do? So then it's like, can we do all the training to keep all that strength and mobility while we do the things that we love? And then how do we set you up for success to keep those results going? Yep. Anybody else?
Perineal massage, what is that?
Perineal massage. So the perineal body sits between the vagina and the anus. You actually go into the bottom of the vaginal opening and you press down. So you're starting to stretch the tissues at the apex of that perineal body. So all those perineal tissues. Yes, ma'am.
You still have a whole lot of happy people.
So I will say, I give some pretty good homework. Especially when it comes to sexual dysfunction, okay? My patients like my homework, okay?
They're very compliant with their home exercises.
They have no problem doing their homework, okay? No. Yes, ma'am.
Okay, you mentioned don't use your certain muscles to do the pelvic floor exercise. So do you have like an illustration of what exactly you're doing in there to do the pelvic if you're not using any of these muscles?
And we had this.
Some training.
We had this conversation, or I had this conversation with a couple people. It is very hard to find videos of that kind of thing happening anywhere unless you're doing like a clinical education course where they don't even give you access to those videos. And so honestly, it would have to come down to like we would have to get into the room together and talk through it. We do a lot of biofeedback as well, so we can put stimulation pads on the glutes and then around the perineal area, and so then you can hear different tones. So if I put a pad on the glute and it was activating, it would be some kind of tone, and then if we put it like an internal biofeedback device into the vaginal canal, it would be a different tone. So then you get a little bit of what we call biofeedback, so you know what's turning on and what isn't. And so then it's like, can we get this tone to come up because that means we're activating the pelvic floor, and can we get this tone to come down because we don't want the activation of the glutes? Does that make sense? I don't have a video for you to be able to see that happen in real time.
Okay, what did you feel when you said you were doing your pelvic? Where can you touch just your body part of where you would feel your pelvic?
I could. So it's underneath.
Okay.
So what we're thinking, so say we're sitting, I'll sit for y'all. Okay, if we sit here and we kind of separate the glutes out a little bit and you're feeling all that external genitalia touching the chair. It's not going to lift up off the chair. It doesn't move that much, but you almost want it to feel like it's coming away from the chair. So the labia, the vagina and all that, you want to squeeze it and then you want to lift it off the chair, but without squeezing your butt. If you squeeze your butt, you're like,
Done.
we don't want that. You don't even know what I'm doing. I could be doing it or I could not be doing it. You don't even know. But so does that help?
Yes.
Okay, perfect.
Any other questions?
When you do the laser, where do you do the
Let me show you.
So with the laser, usually we go straight into the vulva area, but you can also come just above the pubic bone and angle it down more towards the feet, and you can hit some of those tissues there. Because of the deep penetration, that's why it's really great, because you can hit some of those tissues and you don't have to disrobe. You can hit some of those tissues there, but if you are comfortable, we do laser through underneath as well. There you go. Yes, ma'am.
I just have a question about like your expertise in terms of a patient who has like a history of like vaginal radiation and scar tissue and I mean just high level, like I'm someone who suffers from, I have that history, but suffer from like this on and off hip pain postmenopausal like 9 years. And so I'm like exploring, like I'm doing CAT scans to make sure everything's okay. But also I'm wondering, like, do you guys ever use imaging, like CAT scans, to consider, like, in consideration for diagnoses?
Absolutely.
Yeah, totally.
It's kind of a complicated,
Any imaging's gonna help.
Absolutely, yeah, and it really comes down to like how has it affected the tissues. So when we're talking about scar tissue formation, there are some supplements that help us break down scar tissue, so we have a little bit more mobility there. One of the peptides that reduces that is the GHK copper, but there's also a supplement called Wobenzyme, which is a more natural supplement that helps your body break down that scar tissue, so we can attack it in that sense. Dry needling also is very good at breaking up scar tissue, and you can break it up enough to where your body will start to reabsorb it.
Really?
Yes, ma'am.
Vaginal scar tissue? Okay.
Now that's with, I mean, if we're talking true internal, that's a lot of soft tissue mobilization, internal stuff. You can start to break up those tissues. Now with everything else, depending on, so radiation, usually that causes muscle atrophy and there can be damage to nerves. So it really depends on what symptoms you're having post-radiation, and then when we figure out how it's affected the tissues, then we can address it how we need to.
And then that coupled with laser therapy also will just excel that tissue healing process.
Yeah, because especially after radiation, with how aggressive it is, it can limit the cell's ability to regenerate and function properly. So,
Thanks.
Yes, ma'am.
So groin pain was listed on one of the charts. Where do y'all think that isolates from? Like, where do you think the groin pain?
A lot of that is pelvic asymmetry. So we're talking about some rotational components there. When we get an anterior rotation of the hips, we start to close off the anterior hip joint line. There we also have a lot of the femoral nerve and arteries that run there. Your hip flexors that actually sit in that iliac crest. So one of the main hip flexor muscles, the muscle belly itself, sits right here in the front of that iliac crest and then runs down in front of that pelvic rim and then to the femur. So that's where it lies within pelvic floor therapy.
What do y'all do for that?
There's a lot of things that we do for that. A lot of it is, can we fix the pelvic asymmetry? Because if we sit here in this anterior tilt, we're always compressing that anterior joint line, and then we get some compression of the tendons, the ligaments, the nerves and arteries there. So can we start to get a posterior pelvic tilt? Can we open up the front of the hip? Can we release some of the hip flexors and even the quads too, that attach to that ASIS, which is just a piece of the ilium. But everything that we need to do to open up that area, and then we also have to work on the backside of getting the glutes activated. A lot of that you see glute weakness, to keep the right alignment that we need to decompress that area. Yes.
Going off of that, could pelvic floor dysfunction cause hip flexor inhibition?
Yes.
And that's another thing. We have our pelvic floor chair, but we also, the machine hooks up to paddles that can help with hip flexor weakness, glute weakness. We can connect it to all of that to be able to achieve the highest form of contraction and really start to stimulate some strength in there.
That's going to be a big one too when we start talking about the diastasis recti, where we have the separation of the recti muscle bellies. If we can get you taped up and kind of hold that separation closed, and then put the paddle over and get it activated like that, we can start to reduce that separation very quickly. Whereas usually it would just be, we're going to KT tape you up, we're going to do some exercises, and it's going to take 8 to 12 weeks. So.
That's for the whole set? That's for the whole set of abdominal muscles?
That's for the two, so your rectus abdominis are two muscle bellies that run on either side of the center line. So it's one, we group it together into one muscle, but it's two muscle bellies with that connective tissue that attaches in the middle.
So post-hysterectomy, all of this would work?
Yes, yes. Well, because you have to think they have to go through the vaginal canal to do a hysterectomy, so those tissues are affected there, especially when we're talking about scar tissue formation and having to go in there and push some things around. So we can have inhibition there where the muscles don't want to fire afterwards because of the trauma of the surgery, but there's also some pain that comes with that too. So this is, yeah, absolutely, pelvic floor therapy helps with that. Yes, ma'am.
So I know all of this is connected. So I have been struggling trying to figure out exactly where to go for this exact thing. So around May, I like randomly started having hip pain right here, like deep. And I also have PCOS and like trying to get being seen for that, and also waiting to go to a gastroenterologist for stomach issues. So I know like all that's connected. So I'm trying to see how to form my question.
How does that fit into all this?
Yes.
Okay.
Like where would I go? Like, because it's different like areas, but
yeah. No, that's where you start to get into like a multidisciplinary treatment. You do need some different specialties there, especially when we're talking about gastrointestinal and that kind of thing. How we integrate some of the pelvic floor with that is like, can we release some of the abdominals? There are some visceral releases and movements that we can do, especially if we're talking about constipation or colon backup, that kind of thing. Treating the hip is going to be part of the things that we've talked about. Can we stretch and strengthen what we need to? Can we provide stability around those things? With PCOS, there's a lot of hormonal stuff that you need to address. There's a lot of research coming out about anisitols, which are sugar alcohols that our body has naturally. But if you supplement with it, it seems to be tempering down the symptoms of PCOS. But that's really the only main research that they have on anisitols, which is myo-inositol. But a lot of the research is around PCOS, so that would be talking to your doctor about maybe supplementing with something like that. Yes.
Is there ever a time where it's too late to heal diastasis recti?
No. I'm not even saying anything else. No. Thank you. I thought I saw another hand over here. Yes.
I want to speak up for all the men here.
There you go. Go for it.
A lot of the patients I deal with, male urinary issues, and a lot of them deal with their prostate.
Yes. A lot of. Studies show that like males will have pelvic pain after prostate surgery, and this is where we can come into and treat that as well.
Well, before surgery, when they're having urinary symptoms.
Yes.
How does that affect what you do to help the prostate?
So with the male pelvic floor, the only way we can go internally is through the rectum. Now that doesn't always help the urinary incontinence, but if we can increase blood flow, if we can get the pelvic floor functioning more properly, where we're releasing some tension or some weakness there, all the same principles apply to the male anatomy as they do female. The only thing is just the internal is only through the rectum. So we would do similar treatments. They can still sit on the pelvic floor chair. It works just as well for men. We can still do laser through there. A lot of it is the bladder habits, those kind of things. So we can absolutely do some preventative stuff before surgeries and treat any symptoms that they're having beforehand, but then also getting them afterwards to make sure those stay gone.